Committee and House Healthcare Committee. We're meeting jointly today to hear a report from the Affordable Accessible Healthcare Task Force that met during the summer and fall. And now we have a final report. We were fortunate during our meetings to have a consultant work with us. And we've asked the consultant to put the report together and to provide us with some information so that we can understand next steps in improving healthcare, our healthcare system in terms of accessibility and affordability. Representative Lippert and I co-chaired the committee, and we had joining with us 2 other senators and 2 other House members. And I think as you look at the report, you will see that the House members were Representative Donahue and Representative Lori Houghton. The 2 Senate members were Senator Keisha Ram and Senator Richard Westman. So those folks were on the committee, on the task force. We worked very hard. We were limited in the amount of meeting time that we had. I think we were limited to 5 meetings, Bill, Representative Lippert. And so getting the work done to look at turning the Titanic away from the iceberg, trying to improve the healthcare system so that it is more accessible for folks and more affordable for folks was quite a challenge. So the report that you have before you, and as we go through it, you will see there are recommendations, but it means that once we have understood the recommendations, that we will be working, at least in our committee in the Senate, it will be our job to begin a committee bill or to integrate some of these recommendations into a bill that's currently in committee. So there's work ahead of us, but we are extremely appreciative of all the work that Joshua Slen has done for health systems transformation and others who you'll meet today. So I'm going to ask Bill, Representative Lippert, do you have any comments that you would like to make? And then we'll turn it over to Joshua Slen to take us through the report.
Yeah, I would say what we're going to do today is a relatively high level overview of the work of the task force and recommendations. Because of timing and other issues, there's not been a formal adoption of the report, but we will be moving toward that in the next day or so. Again, I think we today will get a high level, and there will be opportunities throughout today for some questions, but there'll be opportunities to ask more in depth and hear more in depth presentations at another point in time. So with that, I think Senator Lyons, I'll turn it back to you, or turn it over to Joshua Slen.
Why don't we? Yes, I think. Thank you for your comments because they're important to the process. Joshua, welcome. Good to see you. And we have 2 documents on our web pages. One is the full report from the task force, and the other is a slide deck. And it's my understanding that we'll begin to go through the slide deck today, and then we'll take another day or so, either separately in our committees or together. We'll be going through the rest of the slide deck in more depth. So I'll turn it over to you.
Yeah, nice to see you again. Happy 2022 to everyone. And for those who don't know me, I'm Joshua Slen, and my firm, Health System Transformation, was contracted by the Legislative Joint Fiscal Office to support the committee, to support the Joint Task Force on Affordability and Accessibility. I'm going to walk through today with help from a couple of other folks that I want to let introduce themselves here in a moment. We pulled together a team in order to address all of the issues that were in the task force charter. And so we did look at a number of different things, including what's going on at the federal level, what's going on in other states, what Vermont has done contextually over the last 20 years. So what could be done today in Vermont and what else is being done today in Vermont, right? So all of those things are important, as you know, because the healthcare is a complex beast, and making little changes can have big impacts. And so with that, I want to turn it over to Beth and then Tim and Lorraine to say, in that order, to just say who they are, where they're from, why they're here, however you want to do your introductions. And then I'll start off by running through. We're going to try and run through about 15 slides today. So the slide deck that you have in front of you is like 40 something slides, and the rest of the slides after slide 15 start to get into the individual options in depth. And we're going to provide some overview of those options, and we can keep going today, to time allowing and how much energy people have. But we expected that we would get through the high level, sort of what we've done, how we got here, and what we're proposing, and that going into the depth on those proposals would be something that would happen at future meetings. So that's the outline for today briefly. And Beth, let me turn it to you, Tim, and then Lorraine to do introductions.
Great. Thank you, Joshua. Hi, everybody. I'm Beth Waldman. I am from Baylit Health Purchasing, and we are a small consulting firm based in Boston, Massachusetts. And I have known Joshua for quite some time. I was the Medicaid director in Massachusetts while Joshua was the Medicaid director in Vermont. And at Baylit Health, where I've been for 15 years, we work with several states, including Vermont, on many strategies to contain healthcare costs and improve access to healthcare. So happy to be here and participate in this project. And I will turn it over to Tim.
Great. Thanks, Beth. Good morning. My name is Tim Hill. I'm a vice president here at the American Institutes for Research, which is a social science research firm here and based largely in Washington, D.C. Happy to be on this project. I think what I bring uniquely here and what we've talked about is my experience at the federal level, thinking through the implications of changes of state policy on federal payment and coverage programs, particularly Medicaid and the marketplace. So I've been very happy to be part of the process and look forward to your questions. Thank you.
Hi, good morning. I'm Lorraine Siciliano. I worked for the state of Vermont for over 30 years in the Department of Health and in the Department of Vermont Health Access and in the Department of Taxes. And I joined Joshua at Health System Transformation, his firm, in 2021. Thanks.
So thanks, guys. And then for those of you who don't know me on the call, I worked for Dean and Douglas, so a long time ago, but I worked for two governors here in Vermont. And prior to that, I worked for 10 years in Ohio with the state legislature. So I worked for about 20 years in state government, 10 of which directly in Vermont. And I worked in the budget office in Vermont. I was the Medicaid analyst. And I was the deputy commissioner of finance and management, and then I was the Medicaid director for 6 years. And so a number of you know me. I recognize a number of faces here, which is wonderful. And a number of you don't know me. And hello, here I am. After I left state government in Vermont, I worked with Beth at Baylit for a time. I worked nationally with Molina Healthcare as a national account exec for them. They're a 99%, virtually 100% Medicaid managed care organization. And since 2017, I've been running my own firm and working across the country on healthcare and almost exclusively on state-facing Medicaid issues. So anyway, it's great to be working on a Vermont project. And with that, I'm not sure how we bring up, we need to share, Lorraine's going to share her screen so that people can see. Ta-da! So we're going to run through the slides. The slides you should be able to see on your screen, and you should probably have them in your own inbox and posted to the website as well. Let me just pause, make sure everybody's ready to go. There's no questions or technical issues.
I think we're probably good. And,
Okay.
and just FYI for committee members, if you have a question, please, I think you're going to have to just say, I have a question, because neither Representative Lippert nor I can see the entire group. And then, Josh, as we're going through, I may, or Representative Lippert may do some explanation as to why something isn't in, or I don't, you may already have that prepared, and some of the decisions that we made along the way.
Yeah, I think there's absolutely, and if the raise your hand option works, Aaron, Lorraine can watch for that as well and cue me if people can't get a word in edgewise, but can raise their hand on their screen. Okay, so with that, Lorraine, the next slide, please. We'll just run through sort of what we're going to do. I'm going to talk a little bit about the task force charge, just as a reminder for everyone, level setting. Talk about the process, because it was a robust, although time limited, as all of our legislative processes are crunched. We'll talk about the process. We'll talk about the summary of recommendations. And then that's where we expect today to end, and not to get into each of the four in detail. So this deck will just be to be continued at that point. As part of the summary, we will talk about why we chose some of these, who they help, how much they cost to implement, and how long they take to implement. And how much they save potentially. So we will talk about some, a bunch of significant issues for each of these options, and probably produce many questions, which is good, and always happens as we go through, big processes. So we welcome those, and those that we can't get to today, we certainly will be around throughout the legislative process this year, and available to meet with committees and explain options and dig into questions. Next slide, please. So the task force charge was to explore opportunities to make healthcare more affordable and accessible for Vermont residents and employers. That charge included a whole bunch of things, if you look at the actual legislative language, right? And include sort of what could we do today, what's going on, at the federal level that we could take advantage of. What has Vermont done before? What are other states doing? How long will it take to do these things? Can we afford to do these things? How much benefit do they have to individuals and families? And how expensive are they to accomplish? And do we require federal approvals in order to accomplish them? Those are all things that are critical as we think about our healthcare system, where we are today, and how we might implement things. I'm going to take just a brief pause here again, and Bill or Jenny, are there other pieces of the task force charge that you'd want to point out?
Well, one of the charges was regarding equity in healthcare. And I believe we'll be commenting on that a little bit later, but that was a standalone important charge to be more inclusive in our healthcare programs and holistically.
Perhaps something more will be said along the way, but one of the other decision points was also, and perhaps reflected in the charge to some degree, that we wanted to focus on areas where we could, which were, that could be implemented in the near term or near long term, rather than just a long-term vision.
Yep. Very good. Thank you very much.
And I'll add one more thing, because it wasn't in our charge, but it is in our charge. And that is, as we look at cost savings to healthcare and the healthcare system, we want to ensure that those savings go directly to Vermonters' pocketbooks.
Great. As always with legislative charges, they're they're beefy, right? There's a lot in them, and there requires necessarily some attendance to detail on what we drill down on. And as we drill down, that we don't lose sight of the larger charge, but that we find things that can be accomplished. And so throughout the process, which I'm going to talk about next, the task force made a number of decisions, and health system transformation supported those decisions with research, meetings, and a number of other pieces. So what I'm going to talk about next is the process that we went through to assure that the task force charge was properly addressed, that we didn't leave things out in the consideration, and sort of how we got from start to finish here. I want to recognize as part of this that I know, we all know, we're never finished, right? State government's going to be around for a long, long time, and people are going to need healthcare for a long, long time. And so we recognize the place in time that we are, as well as the space in time that we are for accomplishing these things. And I think that's just an important backdrop for this. So what did we do? We were contracted in September. And we had the first meeting. We had public meetings on 9/29 of the full task force, on 10/28 of the full task force. We had a meeting in November as well that was scheduled of the first full task force, but it was canceled due to a special session that was scheduled at the same time. And so we had a third meeting on 12/15 of the full task force. So 3 meetings throughout the fall of the full task force. Those were big, long meetings, 5-hour meetings. They're all online, and the materials that were produced and the process we went through are part of those. You know, it's all part of the archives there for that. But we did a lot more work that was happening throughout that time period. We had regular updates, weekly, nearly weekly updates with the task force co-chairs. And multiple meetings with task force members individually and in twos to talk about areas that were of importance to them, and to make sure that we were including the things that were necessary within each of the meetings. So we did meeting preps as well as updates on research and additional items. We had regular meetings, weekly meetings with the Legislative Joint Fiscal Office and Leg Council staff to talk about many things, including what's going on in other areas, what's HROC doing, what's happening with the telecommunications and task force for interstate telehealth, what's going on with the Health Equity Commission, what reports is GMCB and OPR working on. So we wanted to make sure that we were aware of all of those things that were happening, and we leveraged the information that your Joint Fiscal Office and Leg Council have inherently from working on all of those from soup to nuts from the last legislative session and prior legislative sessions. We concurrently, so this is all happening concurrently pretty much over the 4-month period. We had informational interviews, structured informational interviews with healthcare leaders from over 20 different organizations throughout Vermont. And in some cases, we had multiple conversations with individuals from those organizations. So when we get into later on talking about the individual options that ended up in the 4 options that were actually recommended here or will be recommended here. When you look at some of those options, it may be obvious to you, right? Like the moderate needs group option, the Department for Aging and Independent Living, right? That department owns that program, right? They operate that program. And so we spoke to them a number of times. And same thing with programs where the Green Mountain Care Board or other departments would be impacted. We spoke to those departments a number of times to understand their programs and to make sure that we were making recommendations, which the governor may or the governor's staff and departments may or may not agree with the recommendations in whole, but they certainly understand them and what we're doing, right? We're part of that process as we walk through it. And we recognize that there's lots of decision points that often are driven around really tough choices between doing one thing or doing another. And so as part of what the governor's staff recommends and what the legislature ultimately chooses to do, we understand that these options that we're going to get to, fit in that big pantheon of things, right? And so we were careful as we did this to make sure that we understood what was happening in Vermont today, and to the extent that it would be shared with us, what was being proposed to be done tomorrow. And some of that will come out as we walk through things that we chose not to spend a lot of time on, some of which are just as important, but were already being done and sussed out through these interviews that were being proposed and done in other places. So to the extent that important and critical things that do improve affordability and accessibility being done in other places, as we identified those things in talks with leaders across Vermont, we then had task force conversations about to do or not to do, given that they're being done in other places. We also received correspondence from advocacy organizations. We met with those advocacy organizations, in some cases multiple times. And again, to make sure we understood what those recommendations were, and that they were included in the discourse as the task force considered where to go on different items. The input included, as it always does, those informal conversations at the task force meetings, but they included, formal scheduled discussions as well. We spent some significant time early on in the process researching other state activities and federal activities related to the task force charge. And in a number of cases, when you look at the actual option papers themselves, we've included the state activities and the federal opportunities as part of those papers themselves. In a number of cases where other things were being considered in other states, Vermont is a leader in many ways. And so there are lots of things that other states are doing that Vermont has done, has partially done, or has decided not to do, and has done something else similar, but slightly different. And so when we see news articles and papers and presentations from other states and from the federal government, we should, just as a reminder to us, remember to pat ourselves on the back in Vermont and think, wait, have we done this already? Did we do it? And then decide it didn't work well for us. There's quite a few things that others are trumpeting at any point in time, are announcing at any point in time, which Vermont, has done, very well already. And so many of the things that we identify when we do that type of research are things that quickly go to the side, because Vermont's already doing a pharmacy expansion for seniors, already doing an adult expansion, a child expansion, things that we've done, very well for a long time. So next slide, please. Vermont has an all-payer claims database, an APCD. We've had one for a long time. It's a mature database. In other words, that's worked out a number of kinks. There's always improvements that can be made to that, but it's a treasure as far as being able to compare information. It has limits to it. It has limits with the lives that are not included in it, those ERISA payers, so the large payer lives that are not included in it. It has limits because not all of the information flows over from commercial and Medicaid claims in a way that can be compared. But the benefit of it is that the things that are in there can be compared. And so that's an important distinction. We chose to use VCures to mine data and to understand the Vermont healthcare system as it stands today. We recognize that that has limitations. And in fact, in some of the options, meaningfully in the moderate needs group expansion option, there are further data, there is further data analysis that certainly the state will do, should you proceed on that one, that will mine the Medicaid claims data directly, and will not allow for some of the extension of thought to the commercial side of the equation. So how would an expansion impact the commercial side, but would provide additional detail that we didn't mine out in our analysis. So it's a key piece of information, but again, as we do complex healthcare analysis, we're always making those decisions, right? What to go into in depth with the time we have and what not to. And so what I wanted to get across here was that we thought about those things, and the team that's on the phone here, as well as an expanded team that included data analytics professionals and project management professionals and additional subject matter experts that we worked with throughout the process. We gave some significant consideration to what we did and what we chose not to do. So number 9, that was number 9 I just covered. Presentation of policy options, then we presented the options. So we started with over 20 different policy options in the first meeting that could be done potentially in Vermont, some of which are being done in Vermont, and some of which don't fit exactly into Vermont. And then we narrowed down to 7 different options. And then we narrowed down to 4 different policy options to go into depth. So that was the process as we moved throughout the fall and early winter. We drafted a white paper on the Medicare Savings Program, which is included in the final report. And that program is another significant program operating in all states. It is a program that provides assistance to individuals, and it provides assistance specifically to individuals who need assistance because of their level of income with paying for their Medicare premiums in order to help them obtain and keep their Medicare coverage. It fits in with a number of the other options, but it was not included as a full option here. And we can have that discussion, I think, when we talk about the 4 options papers that were included. But we wanted to recognize that that was included as a white paper. And we also included an affordability white paper. And again, affordability is an important piece of what the task force was charged to do. And affordability, that affordability white paper was rolled into the first option on cost growth. And so it fits in that quite well. And again, those white papers, if you go look, are posted, they're available, you can read them. The pluses and minuses to them are there. Who they impact is included, how they impact them, that's included as well. But we made some decisions again about what to include, what could be done, and what the pitfalls of trying to do too much all at once might be, for example, as significant discussions that we had. We then collected and analyzed all of the above stuff and created a final report. The final report is actually pretty digestible. So a moment on that, right? Which is, there's 4 pages of executive summary in the final report. They're reflected in this presentation. That executive summary is reflected in this presentation today, in large part in whole in this presentation today, using the tables and charts from that here in this presentation. There are then 40 something pages in the report, or maybe more than that. But there's a whole bunch of pages in the report, around 40 something, maybe 50 something, that are directly the options papers being described to you in detail. And then there's a ton of appendices that include everything else that we've discussed and received and what the task force did. So all of that is in that final report, should you want to go through it. And there are citations throughout the body of the report that would lead you to, okay, where's this list of other things that you looked at? Or where's this list of people? I want to know who you actually talked to. Those things are in appendices, so they're there as part of the record. Next slide, please. So what did we do? You know, okay, enough on process. What did we actually do? We looked starting back in September, we looked at how much did different things affect the affordability for people, and at what level? How much does it affect? So how many people does it affect broadly, and how much does it affect those people individually deeply? We looked at that. We looked at accessibility. Again, how many people broadly have more access, and how many people, if it's a smaller group of people that get more access, you know, how much more access do they get? How critically important is that access? And where are those gaps in the Vermont system today? And where do we improve affordability and accessibility by a policy that the legislature could create and implement? How long does it take? Time frame. How long is this going to take? Is this a conversation like some of the conversations you've had that have been going on for decades and haven't happened, right? So there are those types of things that can happen. I know, having sat through many conversations about expansion of healthcare, and many experts like myself, right, who have talked to Vermont about single payer and about other programmatic lifts that are similarly attractive and very large and very complicated and very hard to get done, right? And one of the things that we talked about at length with the task force and the co-chairs was sticking to items that we could do, that could actually be implemented, that would not be so large and so complex that we would end up doing a report that didn't bear fruit. And so we recognized that, and there were decisions made around that about what could be done and how long it would take to do it. And then in this same line, number 3, what's the programmatic lift? We're very aware that people are stretched, that state government has had one thing after another given to them to implement, and that we are small but mighty in Vermont in state government, but there's a limit to how much capacity we have and how much can be taken on and how much can be done in any single year or in any multi-year period. And so those things were discussed and talked about, and I know that you'll have those same conversations in committee as you consider different options this session. We considered health equity impact, and honestly, we had health equity as its own line at one point internally that we were talking about. What can we do on health equity specifically? And we moved away from that purposefully to say that health equity is not something that you do by itself. It's something that has to be embedded in each option that gets considered and implemented. And that's because, of course, if we implement a technological advancement, if we use, for example, COVID as an example, we rolled out purposefully nationally and in Vermont as well to priority populations who would most likely be, that vaccine that we rolled out was rolled out purposefully and purposefully to the most vulnerable individuals. And that, successful or not, there'll be a retrospective on how successful that was in different geographies. And I think Vermont has been lauded for our approach and our execution in accomplishing that rollout. But that's an example of considering health equity and protecting the most vulnerable. And Vermont has a long history of that, but we can do better at it, and we can consider equity in different ways. And certainly as we mature as a country, we, on the health equity front, Vermont will learn from what others have done in that space, and we'll be able to implement it. And we have several slides on health equity that we'll talk about. But I just wanted to point out that it is and necessarily needs to be embedded in each option that's considered, in each programmatic option that's considered, and can be discussed theoretically outside of those, but the rubber hits the road when you're actually doing implementations. So I lost the screen. I'm not sure what happened there. Did others lose the presentation? Yeah.
Yes, we don't have it anymore.
So we'll see if we can get that back.
Was that Lorraine?
That was Lorraine. I think
Yeah.
we lost her, it looks like.
Uh-oh.
Oops.
I'm wondering if maybe either Claire or Erin, can you share your screen and put the slide deck up?
Claire, are you able to do that?
I can. Give me one.
So I'll continue talking. Number 5. Sorry.
I would continue with,
Yeah, we have it. We each have it on our iPads, but some iPads are occupied with people. So
Okay. Number 5 on this slide 6 is the level of federal involvement needed. And so here we recognize that there's another committee, the HROC, that deals with waivers and Medicaid issues in more depth. And we, again, made a decision to keep track of that and to recognize that there are things that might be such a big lift, or the federal government isn't going to do it, that we shouldn't consider them. But in other cases that it might be a big lift, and it belongs, the discussion belongs in another forum. And so that's something that we did look at quite carefully. We have a great deal of experience in our team working with federal involvement necessary. But we took that into account where it would be a stopper, or where it would be something that was likely to push the time frame in a significant way. We did not get to the point of drafting waiver language or something like that. Once the policy gets adopted by the legislature, there would be another process, a further process, and this is normal, for the governor's staff to put together at the Medicaid agency level the federal engagement necessary. There may also be some front-end conversations as you develop policy with CMS and other federal agencies to float ideas, and sometimes white papers are pushed up from states to the federal government to get their thoughts on things in advance of an actual application or letter requesting a waiver. And those things are all potentially in the hopper. And for some of the things that we're proposing, it might make sense to do some engagement, almost certainly makes sense to do some engagement with your federal partners. And in the Vermont way, I think that would flow through the administration with involvement or direction from the legislature. So that's where that's where we are with federal involvement. We'll talk about that some, but keep in mind that we tried to stay out of HROC's lane on those items. And so that's how we manage that. And then what's the state and federal cost savings? Certainly important. How we're gonna improve affordability and accessibility for Vermonters, but keep in mind that easy way to improve affordability and accessibility for Vermonters is for the state government or the federal government to pay for it, right? Pick what it is. And if we can get the state government to pay for it in total, or the federal government, even better, right, to pay for it in total from a state perspective, then the cost savings accrues to individual families and individual Vermonters without a state or federal cost. Or there is a state or federal cost, but it doesn't, and it's huge, and it saves individuals and families lots of money. Those things are obviously opposite sides of a coin, right? Where we save Josh's family lots of money by giving him free pharmacy, but it costs society significantly to do so. And so I know that makes sense to everyone, but occasionally as we get into some of these policy discussions, we're like, well, that's great. Let's do that. Let's go ask the federal government to pay for it. And sometimes that's possible, and sometimes it isn't. And some of our options, we're going to talk about the trade-offs there, sort of how much we can do now quickly, and how much it costs to do those things, right? And who pays for it. So the next slide, please. So slide 7. Going to talk about the 7 options now that we drilled down to, right? So I don't know how much time here, but I spent some considerable time getting us to sort of the options themselves. And now I'm going to spend the remainder of the time talking about the options themselves. So before I dive into this, I want to pause. If there's any questions about what we did, why we did it, how we did it, happy to talk about those things now.
Representative Goldman.
Hi. Oh, you can hear me. That's great. I think we just got a letter from a group about being included in the appendix. I was just wondering, what criteria you use for including advocacy letters in your final report.
Go ahead.
So we included the letters that we had available to us. I'm not sure if we missed one, we're happy to include it. But if there's one that came after we produced the report, then it's not included.
No, I think, Josh, I think this is a letter that we actually had and put on our webpage.
Yeah.
So it would be fine to include it in the report, and we can decide to do that tomorrow.
Okay.
It absolutely should be a part of it.
Yeah.
Yep. Just an oversight.
Well, there was so much coming in, and it's difficult to get it all. The thing that hasn't been mentioned that I think is important is in June, I forgot when it was either June or July, I met with the healthcare leaders at NCSL and asked them to support our work with what other states are doing and engage them. So they're not listed. I don't know if they're listed. I don't think they are, but there certainly are a number of folks who were very much a part of the work and helped us with this. We really don't want to exclude anyone. That's not.
I agree completely. Any that we've missed, we're happy to include the information that they supplied and credit that they participated. And so any oversights are on us in the production of the report right now. And we're happy to make those adjustments.
Thank you. I know the chairs got the letter. So anyway, it got sent to all of us.
Yes. Yeah, so we can put that in. I don't think that requires any action on the part of the committee necessarily.
Representative Donahue, you have a hand?
Yes, thank you. Yeah, maybe I can help clarify, because if you look at the report itself, it's the report, it's the recommendations of the consultants. It's not the report of the task force where we might have things that were sent to us, but not the task force, because we actually haven't voted on adopting the report yet.
No, I understand, but there was a letter of September 21st that they hope would be included in the final report, but we don't need to spend another minute.
Yeah, I think we do better to actually continue with understanding what's in
Yeah.
the recommendations.
Let's go. Let's go.
Okay. So on slide 7, we're going to get into the options now, the meat of the matter, right? So as we went from 20 to 7, and I have the 4 that are here on slide 7, and then when we turn to slide 8, there's 3 others that were of considerable importance. We're not going to turn to slide 8 yet, but when we do, there's 3 others that were of considerable importance, but were being done already by the legislature, and that's why we didn't address those with research and fiscal analysis and other things that will be done or are being done in other places. The 4 that we did go into depth on, substantial depth on these, and wrote papers for them, options papers with appendices and all that stuff, are cost growth benchmark and affordability standards. So these fit together really nicely, these 4. They can be done independently, they can be done together, they can be done partially together, and they can be sequenced throughout time. There's a lot of different things you could do. But cost growth, think of these in a few different ways here. Cost growth benchmarks and affordability standards get implemented in order to manage the total cost of growth in the healthcare system. So you have a $6.5 billion healthcare system in Vermont. You have a whole series of agencies, including the Green Mountain Care Board, DVA, OneCare, that all play a role in that, and huge institutions, right? UVM Medical, all your FQHCs, RHCs, so federally qualified health centers, rural health centers, community mental health centers, all of those different providers and insurers, Blue Cross, MVP, workers' comp, all the public employees, all of those folks buy healthcare and consume healthcare in Vermont. And the cost growth benchmark and affordability standard says, hey, we could apply an affordability standard as other states have done, and say that for a family, it shouldn't cost more than X. And we can apply a cost growth benchmark that says, for the state, we should not grow more than Y. And we could tie that to things like wage growth, CPI, consumer price index. You can tie it to different things. That's a high level thing, right? And if you save money on it, who saves the money requires tools to make sure that, to Senator Lyons' comment earlier, that the money that you save doesn't accrue to Blue Cross or to UVM, to a big institution. Some of it may, but that we have mechanisms in place to have those savings that happen at the cost growth benchmark and affordability standard level, that those savings accrue to families in Vermont. So think of number 1 as that high level, what are we trying to do as a state in managing growth in the future so that healthcare doesn't continue to gobble up more and more as a percentage of household income. It allows us to put a target and then to build underneath that target specific things that we would do as a state in order to, in 2022, 2023, 2024, in August, right? Pick a date, like we're actually going to implement another program that would have an impact and that would help to meet our cost growth benchmark and affordability standards, right? Think of all the other options underneath here as options that would help to meet our cost growth benchmark, right? Next year and the year after. So extending moderate needs supports, you have a moderate needs program today at the Department for Aging and Independent Living. It helps individuals with their activities of daily living. It helps individuals who need help getting in and out of bed and going to the bathroom and getting their groceries. And this is important. We'll talk about it later. It's important because when you hit 65, If there's 3 of us standing here, 2 out of 3 of us will need those ADL supports at some point before we pass on. Once you hit 65, you'll need those supports. There's individuals that need it underneath. It's just that underneath 65, below 65 as well. And so we don't miss them as part of moderate need supports. But when we supply those supports, we believe that we improve people's quality of life, importantly. We know that there are individuals who don't access those supports for lots of different reasons. And we know that when you do access them, that you are able to stay in your home and not go to an institution for a longer period of time. And so that's an important thing. Vermont's done a great job at this over time. An extension here is one of the options. Public option. The public option is an insurance option. So think of this as a price option. How do we control price in the market? How do we improve access to healthcare is one thing you can think about public option. In some states, people don't have access to insurance products. In Vermont, the place that we have, the singular place where we have a problem here is in our individual and small group market. And so when we think of public option here, we're not thinking of it. In some other states, you might implement an insurance product that the state government has mandated that is a smaller benefit, right? It's not a benefit that's as broad as other products. We don't believe that would be very attractive in Vermont, given the market and where we stand as far as providing accessibility to lots of different services. And so what we're really talking about here is addressing the employer market, the small employer market, right? About 35,000 individuals in that market today. The costs there have spiraled upwards. And it is a place where we can control price with a public option that has impacts for sure. But those impacts are directed here at being positive to the employer purchase of insurance and offer of insurance at the small group level to individuals and their families. Notice that cost growth benchmarks, high level, extending moderate needs, very specific to a group of individuals, right? Up to 18,000 individuals that we could extend moderate need supports to, primarily older folks. Public option, a price control mechanism that extends to up to 35,000 individuals, perhaps some more if we looked at the individual market, but we're really targeted at the small group here. And primarily those folks are younger and healthier. And price is the problem there, right? So different groups being impacted there. Expand the blueprint for health. So here's another one. Vermont's done a great job, right? Don't forget again to say, hey, we've done a great job. We have a nationally recognized community health teams all over Vermont that provide supports to individuals, including individuals that are opioid dependent or substance use dependent, as well as others who have chronic conditions and just complicated healthcare that they need help coordinating and managing. Our blueprint teams take referrals today and support individuals across Vermont, right? So what we say here is we should expand the blueprint for health, but we should apply some return on investment to this. We should apply some ROI analysis, and we should apply some front-end identification and stratification of the population in order to assure that we are helping folks and we can demonstrate that the blueprint is successful financially to the payers and providers in the state, as well as the state government. That's important because C number one, in order to drive down our cost growth over time, we have to demonstrate that each one of the things that we do from a public policy perspective impacts number one. And we have to do that in a diligent way over time. So for everything that comes before us. one of the items that's not explicitly listed here, but that health system transformation is recommended, and we discussed at length with the task force, is having a statewide population identification and stratification and return on investment vendor that would be located in number one, that would be hired and utilized to do the analysis in a standard way for big policy changes that were coming before the legislature, so that you would always have in front of you, when you had a proposal to consider, you would have a vendor, a third party that was doing that analysis consistently for you on the front end. Who is this going to help? How much is it going to cost? How much could we potentially save? And then in follow-up in future years, how much did it cost? How much did we save? How many people did it help? And that's the way we improve affordability and accessibility over time systematically, right? So when we say these things fit together, these aren't the only things we could do, but keep track of the fact that these are things that Vermont needs today. They fit into the context of what Vermont has done in the past. They're things where we believe the federal government will be a partner and want to support what we're trying to do here, and have a financial stake in what we're trying to do here, happily. And they're items that can be done in pieces, so that you don't have to bite off extending moderate needs to 18,000 people today to start helping, right? You could extend moderate needs to 500 people today. You could extend it. And there's lots of ways to go about slicing these up, which we're going to get into in the next slides.
Josh, as we went through a lot of this in our task force work, we did identify programs and people that we felt were key to the success for the chosen options. And maybe as you're going through, you could talk a little bit about our discussion or support for primary care in particular, since that is sort of the bottom line for the options that we're looking at on the provider side.
Yeah, for sure.
Okay.
For sure. Next slide, please. So a few other things that that task force very interested in, but we chose not to pursue as full options where we applied the full Monty of analysis to, because they're being done in other places, right, in Vermont. Not that they're not important, but the postpartum expansion, so that's a Medicaid option to expand for moms and babies to 12 months. And we understand that the administration is proposing or has proposed that, or is doing analysis on that for the legislature already. And so we didn't pursue that analysis. We believe, HST believes that is something that should be done. It's very close to a no-brainer to do it. And that's important from an equity perspective, and as well as when you think about costs, the federal government's going to pick it up for the first period of time. Remote access to care, there's a whole bevy of things happening in the legislature on that, from coordinating telehealth across multiple states to supporting broadband expansion and technologically approving options to provide technology in the home. And so all of those things are being done in Vermont. It's not that we couldn't do more there. It's just that's a crowded field where there's a lot of attention already. And so the task force chose not to spend our research time on that. Pharmacy benefit manager regulation. Again, there's a bill on the wall. I understand that the task force is supportive of. Not to speak for the task force, but I believe that's the case. I've heard it said. And so how that comes out at the end of session will be what it is, but that's another area that we believe at HST is an important area to consider. And the task force chose not to have us pursue it, since it's being pursued in other areas. Next slide. So I talked about this already. I think implementing options strategically, how they fit together is something to consider. And also importantly, that they should be evaluated in relationship to initiatives that are already underway, right? Or under consideration. And I know that you do that as part of the legislative process, and that my friends in the administration in Vermont and in the advocacy community will continue to make sure that you are aware of the things that they are doing and that they are advocating for as part of the process, as they should. So I just wanted to point that out. Slide 10, next slide, please. So here's the summary description. I'm not going to spend a lot of time here because I think I spoke about the summaries of these in the prior slide when I was talking about them. These summaries include a little bit more detail than I spoke about, or slightly different detail. And I'm happy to take questions on them. I'm just looking through to see if there's something in particular that I wanted to note here. Okay, I'm good. Next slide. So here's the summary justifications for these slides. I mentioned, for example, that under cost growth benchmark and affordability standards, that we need to have underneath it a return on investment, and that we need to tie what we choose to do to accelerating savings so that we can capture those savings for ratepayers in the system. Also, I mentioned as part of this that 70% of us, once we reach 65, will need supports with ADL. I think that's a primary justification for extending moderate needs supports. And in the public option, that we are, and I want to be explicit about this, you know, when I talk about using it on the price front for small employers, that we are talking about price being different here as a primary way to drive savings. There's other things you can do, but competition's been talked about by my friend Tim. And in Vermont, we know that competition is a different beast than it is in California or New York, right? Where New York has 19 plans in the Medicaid space. Last time I checked, maybe it's 21 or 18 now, but it's you know, a dozen and a half or more. And that type of competition across different offerings in the space is just not going to happen in a small state like Vermont. And so competition is different here. But I also wanted to be express in the point that having a rate that is below today's commercial rates doesn't mean that every rate is below in a design in order to create savings. And it doesn't mean that every rate is so far below that it would be devastating to the healthcare system, right? And so some of what you will hear from folks that will be against the public option with a rate structure that's differentiated will be that this is an apocalypse, right? Like this will be the end. And we have workforce issues, and it's hard to, and let me say, we know that there's a workforce group, and we know that there are workforce issues, and explicitly the workforce issues that we have, not enough nurses graduating, doctors at the primary care level being paid less than specialists, that, you know, and so making it harder to get people to go into and stay in primary care and locate in rural areas. Those issues aren't new issues. They are significant, and they are national. And so when we raise rates for nurses, for example, in Vermont, and our rate goes to, say, 10% above the New Hampshire rate, it puts New Hampshire in a position of needing to raise their rate, right? So we become, we have an issue as a state and we have to deal with it. And there's a whole workforce group, and the task force chose not to deal with the workforce issue because it's being dealt with in other groups explicitly. And that, I think, is the most important thing. And Josh will say also that this is an issue on the workforce front that we shouldn't allow to stop us from doing other good things. So that's a Josh statement, right? And others can disagree with it, but that we will have the workforce issue for a long time, and we will have lots of options that are on the table that push dollars to and other incentives to keeping the workforce vibrant in Vermont and attracting folks to Vermont. And we err if we allow the workforce issue to become the reason we don't do other policy things. So I'm going to move off of public option now and expand Blueprint for Health. Again, I'm purposefully putting things here that I know are challenging, right? These justifications on page 11 include things that we know are challenges. The ERISA payers, the large employers who have their own, who are carrying their own risk, and have an ASO or a TPA, a third-party administrator like Cigna supporting their lives in the market, are different beasts because the state can't regulate them in the same way. My friend Beth will talk about how other states, those payers do participate in the cost growth benchmark and affordability standards exercises and supply data. And I think that they can be influenced to do so in Vermont as well. But it is true that you can't mandate them to do stuff like participate in the community health teams, the Blueprint health teams. But we can make a case for them, again, go back to the ROI, that paying for the health teams is something they should do because it has benefit that accrues to them. If we can draw the line for them with our return on investment, then we can pull those ERISA payers into participation in supporting the Blueprint teams, for example. And I believe that is true. And in order to know that it's true, we would have to do that analysis on a regular basis. And that's one of the recommendations. Next slide, please. Okay, who does it help? How many people does it help? How long does it take to do this? So the bottom line is that if we do this, if you look in the estimated number column, the third column over there, the cost growth benchmark helps everybody. As we push down rates, helps every ratepayer in the system. So it helps all Vermonters. And, you know, let's not err and say that if I'm on Medicare or Medicaid, it doesn't help me, because to the extent that our growth is lower, we can afford to pay for more services, right? Like price is lower, units can go up, right? And so there's a direct relationship inside of the healthcare system to things like increasing rates for primary care. So one of the issues that we have is a primary care workforce issue. Another issue that we have is not enough access to those appointments, those primary care appointments, right? To the extent that we are able to implement a public option, let's just use that as an example, where we push down on lots of rates, we could still push up in that public option on primary care rates. Right. So you could push up on certain rates and down on others in that design purposefully to encourage and support primary care. Right. And in addition, as we do rate setting at GMCB for our payers, we could push primary care rates. And other states like Rhode Island have done exactly that, which is to push up primary care rates as part of rate setting. So those things are things that are underneath the hood here as we start thinking about how these play off of each other and how we impact more Vermonters, how we make things more accessible. Hey, I don't have access to primary care today. What can we do about that? Can we push on price with a public option? Can we push on price with the cost growth benchmark and affordability standards? The answer is yes in both cases. There's reasons why that has other impacts that should be considered. But I wanted to point out that as we look at affecting as many Vermonters as possible and as deeply as possible, we are trading off affordability and accessibility throughout these packages, right? Like necessarily we are. So impacting 600,000 people plus with cost growth benchmark and affordability standards, but not impacting them gigantically or all equally, right? When we get into doing the moderate needs supports and the public option and the expand the blueprint, we're really targeting different folks for different reasons. In the moderate needs, 500 to 18,000. Wow, that's a big range, right? Wow, that's a big range. Purposefully a big range, because we could impact 500 today and 500 more tomorrow, and not blow the bank, like not be able to afford it, right? Like if we tried to implement 18,000 today, I recognize that's a big lift, right? There's going to be a lot of state money, a lot of federal money that has to go to support that right away. And frankly, there's almost certainly not 18,000 additional people that need that support today. But over the next 5 years or 6 years, that's a number that absolutely we could build up to, and individuals will come on and need those supports as we go. Public option up to 35,000. Yeah, and that's a real number. That's about 70,000 in the individual and small group market. About half of them are in the small group in the employer plans today. And so to the extent that you have that we implement a public option specifically targeted to small employers, you impact 35,000 people, and the number of employers is significant, those small employers, right? And the blueprint for health, the analyses that we've seen show that about 10% of the state's population at any point in time could benefit from care management services. We don't have the counts of everyone in the state that's receiving care management services today. There's lots of different ways to count that. There's lots of different ways to define care management and care coordination. And that's another piece of work that certainly could be done and perhaps should be done as part of this expansion, and certainly is something that is doable. But those community health teams help people today in lots of different ways, and they're not all identical they're nowhere near identical in how much help an individual receives for how long and for what services. And there are other care management and case management services. So let's keep this in mind as we think about making the case for the ROI analysis and actually doing stuff in the future. Blue Cross Blue Shield, UVM, Dartmouth, the FQHCs, go around the list, all do some amount of care, case management, care coordination. The definitions are different. The programs that are being utilized for different groups are different, so there's case management and care management that have to do with individuals receiving high cost services or lots of services and managing on that front. And there's coordination of different types of services for people. We don't have to at the legislative policy level get into all of those nuances. What we do have to know is that in order to convince the system, the payers, the big integrated health systems, the primary care physicians, in order to convince them that what they're referring people to is something they should refer more people to, we have to demonstrate that there is a benefit, that there is an outcome benefit to the individuals and that there is a cost benefit to the payers. And if we can demonstrate those two things, then we'll get increased referrals to programs, and we will guaranteed that will happen. If we can demonstrate that there's a cost savings to the payers and an improvement in quality to the individuals, you will get increased referrals to a program. And that's what we're targeting here. Next slide, please. So what does it cost to implement these things, and what's the ongoing costs, and how much savings is there? So first
Josh,
one was, yeah.
Josh, I want you to continue, and just to know that the House Healthcare Committee has a hard stop at 10:30.
Okay, I will spend my time on this slide then. There's a lot here, and
Yeah.
in 7 minutes, I'm not going to get to health equity, which is the next two slides. We can pick up on health equity. I don't think I can do both in 7 minutes.
No, I think, and our committee will be picking this up on Friday. I think House Healthcare will be picking it up another day. So let's go through what you can on this slide, and then we can always retrace our steps at some point.
Okay, so I'm going to start with potential savings on the right. That's sort of the most exciting thing. The newspaper man would start with the potential savings, right? There's a lot of savings here. So, but I want to point out that these are savings that are hypothetical, right? Like they could happen, but it depends on how we implement all the stuff under the hood to the left, right? Like how big do we go to begin with how many people we enroll, and how much do we spend on analytics and ROI, and what are the policies, what are the policy levers that we give and the programmatic levers that we give to the departments, so how aggressive do we allow folks to be in, essentially. So 1%, we have a $6.5 billion health system, 5% growth, 1% growth is 65 million a year. So if you have a 5% growth trend and you carve it, you say it's not going to be more than 4%, then you save 65 million. And we can do that. States are doing that. It requires levers underneath the hood, like, okay, in order to save that money, how do we do it, right? And so I wanted to point out for the cost growth benchmark that you have to do the things down below, or some other things down below, that allow us to achieve those savings. Just saying we're going to slice 1% off of your trend, it's got to come from somewhere, right? And so you can push on price, you can push on utilization, you can push on coverage. There's a lot of different things you can do to to tamp down cost growth. They all have impacts on some buddies and in some amounts. So what does it cost so let's go down then. I'll stay in the potential savings on the right-hand side. Skilled nursing home annual costs are in Vermont, that's actual number, $117,348 on average per year for a skilled nursing home in Vermont. To the extent that we roll out moderate needs supports and we avoid 100 admissions a year, we save $11.7 million. And that's not unreasonable to consider that we would extend moderate needs supports and that we would avoid 100, 200, 300. It depends how many people we extend those supports to, and how we target the individuals that we extend those supports to. So again, doing that identification and stratification of individuals and extending supports in order to save dollars is something that can be done. There's equity choices in there. There's a bunch of significant issues in there about how to roll this out that we need to think about as part of it. But certainly there are cost savings to doing it. Public option, and Tim, keep me honest here. Nevada, is that a Nevada number, the 1,300? Or yeah, it is. Okay. So in Nevada, they targeted 1,300 a year. And if we were to target a savings number, so again, here, when you roll out a public option, you can say, we're going to save 5% off of last year's rates. We're going to save 10% off of last year's rates. Now let's figure out the program designed to do that. And so you can target this number to not any number you want, but to a broad range of numbers. And this is not an unreasonable number to target it to, but it will have an impact. It is aggressive, right? It is an impact that folks will claim will have a deleterious effect on workforce, for example. And that's something to keep in mind and to think about. The Blueprint for Health expansion, honestly, the literature is mixed on the range of financial outcomes for care management. So see my earlier comment that care management and case management, care coordination, there's a broad range of things you can do. If we do a specific targeted group of things and we get that definition down, we can peg an ROI to it. If we do sort of broad range of all kinds of different stuff, the ROI disappears in the melee, right? It disappears. And so that's something where diligence is really important to identifying and stratifying populations and going after interventions where there's actually a benefit. We can go after benefits that are harder to measure, but see my earlier comment about getting payers to drive people to programs. They'll drive people to programs consistently over time if there's a return on investment from those programs, if they save money on those programs. Tying it to improving health outcomes is also true. So if we we look for those things where we have health outcome improvements and payer savings, we can guarantee that we'll continue to drive enrollment. When we can't do both of those things, we can't guarantee that we'll either have savings, one, or two, that will continue to drive people to those programs over time. I recognize that we are right at the end. The ongoing costs and the cost to implement are estimates. Happy to talk about those in detail. I think that the investments in the cost to implement, for example, on cost growth targets, that 4 to 6 million, there's a bunch of stuff in there. There's staff for GMCB, or who I think that's where that would happen, as well as for the vendor at the statewide level. And that assumes 3 years of those costs for those individuals in order to, for example, say, if you wanted to use one-time money for the things in the cost to implement and say, hey, in order to do this, we could do it for 3 years, because you can't do it for 1 year and then say, did it succeed or not? You have to do it for 3 years so you can actually look at all 3 years and see how you succeeded. And then in the ongoing costs, that's after that implementation period. So I just wanted to be clear that you don't add these together and say we have to budget that this year. That's not the case. You would implement the cost to implement's for now, and the cost for ongoing is for after. We are right at the end, and so I wanted to be respectful of that. And there's so much. I hope that it was.
Well, Joshua, thank you. Claire, we could take the slides down. Thank you for that. And thanks for chipping in. Lorraine lost her electricity. That's why we lost her.
Right.
Yeah. So, Joshua, thank you. And our Senate Health and Welfare will dive into this a little bit more on Friday, and then we'll be setting up additional time in our committee to go through the report and to see what it is that we might want to put in place through legislation this year. And I know that House Healthcare will also be working on this, but the Senate Health and Welfare Committee has been given the honor of beginning that process. So we'll look forward to having you in our committee. I'm sorry that we don't have more time today for questions. We're going to have to go back and do that, whether individually or collectively, or two committees together. So we will definitely do it in Senate Health and Welfare.
Right.
Anything else,
So-
Representative Lippert?
No, we do have other witnesses awaiting us. So thank you, Joshua and others. And we will return to this after consulting further with Senator Lyons and the Senate Health and Welfare Committee. So with that, I would just encourage or suggest that House Healthcare Committee members go off of the joint. We have to move out of our joint Zoom room and go back to our individual Zoom room at this time. Thank you.
Terrific. And Senate Health and Welfare, just stay right here. Don't go away.
And Senator Lyons, you're done with me for today?
Yes, but we'll see you on Friday and look
Yes, you will.
forward to it.
You're
Thank
very
you.
good. Thank you.
Yeah.
Ginny, were we going to take a 5-minute break?
We're not yet. I just need to ask Jen Carby one question and then we'll do that. Jen, do you have a 10:45 meeting?
Yes, I'm in Senate Health and Welfare. I mean, in House Healthcare at 10:45.
Oh. Well, I think what we'll do, I'd like to take a break, but I think given Jen's availability, we'll go right into our next agenda item, which I think is S74. I'm pulling up my other agenda. Yeah. And so we'll go to that. Is there, Aaron, is there a way to disconnect the House Healthcare Committee room from our meeting?
Yeah, let me look at that.
I mean, it's fine having people around. Oh, there they go.
Oh, there we go.
All right. Terrific. So Jen, thank you for being here, and hopefully we won't keep you too much longer than your 10:45 stopping time, but see how it goes.
All right.
Okay. What have we got?
So Jennifer Garvey, Legislative Counsel, we have the amendment that we looked at yesterday to S74. I think I made a couple of cleanup changes while we were talking, and I've had it edited. They didn't make any changes, so it should look pretty similar. Do you want me to put it up on the screen?
Yes,
And
please.
walk through it? Okay.
Yeah.
Right. Can you see that language?
Yes.
Great. This is the committee strike all amendment to S74. And again, that's an act relating to modifications to Vermont's patient choice at end of life laws. This in section 1 adds 2 definitions to the chapter, a definition of healthcare services and a definition of telemedicine. And I did take out that reference to including dental services because that was more applicable in the context of the health insurance statutes, which is where I took the definition from. So 2 definitions there that get used later. In section 2, in the requirements for prescription and documentation and immunity, this is the section that lays out the steps that a physician needs to take and document in order to not be subject to civil or criminal liability or professional disciplinary action for prescribing medication to a patient with a terminal condition to be self-administered to hasten the patient's death. So we've added language now that says the patient, this is the first oral request, the patient made an oral request to the physician in the physician's physical presence, and we've added or by telemedicine if the physician determines the use of telemedicine to be clinically appropriate. And it's similarly in number 2, we have not fewer than 15 days after the first oral request, we had the second oral request made to the physician in the physician's physical presence or by telemedicine. And again, if the physician determines the use of telemedicine to be clinically appropriate, the request is for that medication. And we skip down to number 5, the physician determined that the patient was suffering a terminal condition based on the physician's, and then I've moved the physical examination down and added the A instead of the. So the patient was suffering a terminal condition based on the physician's review of the patient's relevant medical records and a physician's physical examination of the patient. Apologies for the phone in the background.
No apology needed.
It's likely about my car's extended warranty. And then we have in D, just the change for gender, non-gendered language. So had made a voluntary request for medication to hasten the patient's own death. And then in number 6, the physician informed the patient in person or by telemedicine, both verbally and in writing, of all of the following. So there's the addition there of telemedicine, and that we have the physician wrote the prescription, and then we've taken out no fewer than 48 hours. So the physician wrote the prescription after the last to occur of the following events. And then these changes are in A, I guess just in A is for non-gendered language. But we have changed this to be the last to occur of A, B, and C. Again, I don't believe there's a substantive impact, but I agree that it is much clearer to say last to occur of A, B, and C. So the patient's written request, the patient's second oral request, and the physician offering the patient an opportunity to rescind the request. And then we have that the physician either dispense the medication directly, and this again is a change to be non-gendered language. So this is ensuring that the physician was licensed to dispense medication in Vermont, had a current DEA certificate, and complied with any applicable administrative rules. And then we've skipped the rest there. And then in 14, we have in A and B, we have changes for non-gendered language. So changing from the patient's request for medication to hasten his or her death, it's the patient's own death. And same as well in E. And then finally, we have section 3, which is the limitation on actions provision. And in that case, we have added a new subsection C that says no physician, nurse, pharmacist, or other person licensed, certified, or authorized by law to deliver healthcare services in this state shall be subject to civil or criminal liability or professional disciplinary action for acting in good faith compliance with the provisions of this chapter. And it would take effect on passage.
Okay. Questions while we, for Jen on the
I can put it back
language?
up if it's helpful.
No, it's okay, I think, and if there's a specific question, we can go back. Committee questions? Thank you, Jen. I think that the changes that were made are terrific, really, really help. And we're getting to a point now where we feel that we've done some work. I did ask Aaron to put another letter of comment on S74 from Ed Mahoney, who is a priest, has worked for many years at, not a priest. Oh, it's his brother. Okay, sorry. Yes. All right. Against the, in a contrary position to S74, he was also active in testimony when the original Act 39 was passed, but I've asked Aaron to put it up on our webpage so we have that for reference.
Madam Chair, can I just
Senator
ask-
Senator Hardy.
may I ask Senator Carby a question?
Yes.
Jen, just I was scrambling to try to just pull up the statutes, but you'll know the answer to this. So on page 5C, that paragraph C, there, paragraph A and B, can you just remind me what those are? One of them is about licensure, I believe, for the same sets of people.
Right. I think one of them is about, and I will pull it up as well, but I believe one of them is about professional disciplinary action for acting or refusing to act. But let me pull it up. So A is that a physician, nurse, pharmacist, or other person shall not be under any duty by law or contract to participate in the provision of a lethal dose of medication to a patient. So no provider or anybody else has to participate. And then B is that a healthcare facility or healthcare provider shall not subject a physician, nurse, pharmacist, or other person to discipline, suspension, loss of license, loss of privileges, or other penalties for actions taken in good faith reliance on the provisions of this chapter or refusals to act under this chapter. So that's
Okay.
focusing on action that might be coming from a healthcare facility, healthcare employer, healthcare
Got it.
facility or healthcare provider.
Okay, great. Thanks. I just,
So there may be some overlap between B and the existing B and the new C, but I think new C is broader.
great. Okay, thank you.
Okay, good. Any other questions for Ledge Counsel Carby?
Madam Chair, I just want, you mentioned another letter, and I sent to the committee the letter from Dr. Barnard yesterday responding to the question that.
Yeah,
Senator
and Aaron's put that up. It should be up on our webpage. Yeah. That should be there as well. That was very helpful. Thank you for getting that information. It's about the medication and how the medication is being looked at professionally. Anything else? Wow. Okay. Unless I hear differently, I think we're at a stage to move the legislation, and I would accept a motion at this point. And we have a clerk ready to act. Senator Hardy.
Sure, Madam Chair, I would move S74 as amended in draft 1.2, the strike all amendment dated 1/18/22. Is that the correct draft, Jen? Okay, thank you.
All right, there's been a motion. We don't usually have seconds. We haven't done this in a while. Okay, discussion. All right. Then, Mr. Clerk, Senator Clerk, please call the roll.
All right. Thank you, Senator Lyons. I'll call the roll for S74 draft 1.2. Starting with myself, I am a no vote. Senator Cummings,
Yes.
Senator Hooker,
Yes.
Senator Hardy,
Yes.
and Senator Lyons.
Yes.
So I have a 4-1 passage of S74 from committee.
Thank you very much. Thank you, committee, for all your hard work on this. It isn't an easy issue by any means. And this is, for me, it's about the 5th or 6th time we've been through some of this conversation over time, but the improvements I think that are being made to the program will help people who are in very difficult situations with their health and approaching death. So thank you for that. I'm looking for someone to report this on the floor. Senator Hardy, thank you. That'd be great. And so this, let's just remind ourselves of process. So at this point, you need to have the clean copy, and you need to have the vote and your name, and then you send that to John Bloomer.
Yep.
We
Jen,
forgetting
should I just
anything? We
send
forgetting
this-
anything?
Should
Go
I
ahead.
send this version? Sorry. Should I send this version, Jen? Is that the right one?
Perfect.
Okay,
That's the right
great.
one. And I don't, when we're in the building, they like need the physical copy of the bill. But I don't know how that works.
I think it's an
remotely, so-
email. I think it works electronically.
Right,
Yeah.
right. But the
I don't know.
original
Oh,
that the amendment goes with, but I
I'll
think,
just copy you on the email to
Okay.
Secretary Bloomer if he needs something.
That's fine.
let us
If you
know.
need something, it's either from me or from Aaron, so we'll figure it out.
It's probably, yeah, where it would have been in our committee, but I don't know where it is now. Yeah,
Exactly,
that's
yes.
the
and I don't know
question.
that
yeah.
we've been getting the physical one. So
Right.
they may still have it in the Senate office.
Just
You
a point
know-
of clarification, Senator
Yep.
Lyons.
Yep.
So I have taken the role, it would be my responsibility as clerk to inform Secretary Bloomer of the vote, correct?
No,
Oh,
I'll
okay.
do that when I give him the bill.
that goes up with Senator Hardy when she is the reporter.
So my responsibility is over.
Yes, for now, but don't forget you're still clerk.
Tough, that's a tough work, tough job.
Don't worry.
I do have to communicate with you, Senator Terenzini, on the vote a little bit, but yeah, it's not, I will email.
Okay, so we're all clear then? Ruth, it's in your hands. Capable hands. Okay, thank you, Jen, so much for your work. We greatly appreciate it. And committee, I think, Aaron, we're going to go off you